In this video we're going to be dealing with the anterior triangle of the neck and some of the smaller triangles that we will find within the anterior triangle. Let's remember the borders or boundaries of the anterior triangle, which would be, for instance, the midline of the neck, which I've superimposed over here, the inferior border of the mandible, and the anterior border of the sternocleidomastoid muscle. So the sternocleidomastoid, or SCM, will separate the anterior triangle from the posterior triangle on the other side. So what I've done now, I've rather crudely superimposed the outline of these smaller triangles that we can subdivide the anterior triangle into. So one would be the submental triangle, which is actually fairly small. It's also the only unpaired triangle, so there's actually only one of these. And the submental triangle, as you can see here, this is actually outlined in black, is going to be bounded by the anterior bellies of the digastric muscles and the hyoid bone. Then you have the submandibular triangle, which is going to be over here, that is outlined in blue. Okay, so that will be bounded by the inferior border of the mandible and the anterior and posterior bellies of the digastric. So here's the inferior border of the mandible, here's the posterior belly of the digastric, and here's the anterior belly of the digastric. So this is your submandibular triangle. Then you have the carotid triangle. The carotid triangle here is bordered or outlined in pink, and you can see that the carotid triangle actually has a border of the posterior belly of the digastric as well, the anterior border of the sternocleidomastoid, and the superior belly of the omohyoid right here. And then last but not least, you have the muscular triangle, and the muscular triangle has a boundary here in the midline of the neck, the sternocleidomastoid muscle, and also the superior belly of the omohyoid. Okay, so now we've switched the view into an anterior view, and we also have a cadaveric image here that shows us the respective muscles. So the boundaries of the anterior triangle of the neck, we can see it nicely here. Everything except for the midline of the neck is highlighted. But so the midline of the neck, together with the mandible and the sternocleidomastoid, forms the boundaries of the anterior triangle. Okay, so body of the mandible, sternocleidomastoid, the midline just would be depicted as a straight line down here. Then you have your submental triangle. Remember, this is the only one that is not paired. It actually really does look a little bit like a triangle between the two digastrics and the hyoid bone. Then you have the submandibular triangle. As you can see here, your anterior and posterior belly of the digastric. These are actually innervated by different nerves. The anterior digastric by a branch of V3, the nerve to mylohyoid. Innervates the anterior digastric, but the facial nerve innervates the posterior belly of the digastric. And then actually here's the mandible, the inferior border of the mandible. Here is your carotid triangle, and for the carotid triangle you can see it's the superior belly of the omohyoid, the anterior border of the sternocleidomastoid and the posterior digastric, and then the muscular triangle where you have the midline of the neck again, and the sternocleidomastoid and the superior belly of the omohyoid in this case. So what we're going to have to do is we're going to have to go through every single little triangle and see what the deal is with them and what kind of information can we learn from having a closer look at those. So let's start off with our submandibular triangle, alright? You can see here are the boundaries of our submandibular triangle one more time. You have the border of the mandible. You also have the posterior and the anterior digastrics. So what else do we find in here? So the contents of the submandibular triangle is going to be your submandibular gland, your facial artery, your facial vein, your hypoglossal nerve, which you can see poking out back there, and a couple of lymph nodes, which I have hidden from view just to keep the image as unmessy as possible. The roof of this triangle would actually be formed by the investing layer of deep cervical fascia, and a deep boundary, so floor, will be formed by the mylohyoid and the hyoglossus muscles. So if we zoom in a little bit here, we can see this is your mylohyoid muscle, and this is your hyoglossus muscle. You should also be able to find this muscle here, which is called the stylohyoid, because it comes from the styloid process and then attaches to the hyoid bone. You can see that it actually crosses right over where there's this tendinous part, where the tendinous sling or intermediate tendon that connects the anterior and posterior digastrics to each other. And the stylohyoid is interesting because it actually splits and straddles the posterior digastric, kind of like someone riding a horse or something. It's straddling the posterior digastric, and then its fibrous tendon attaches to the hyoid bone down here. So next up is our submental triangle. This is the only unpaired triangle we actually have, and also this one will cross the midline of the neck. And there's not really very much in the triangle. There might be some submental lymph nodes, but other than that, we don't encounter a lot of really high yield material in here. So you can see here's the apex of the triangle, which is the mandibular symphysis. There's the left and the right digastrics. Remember what it's innervated by. The digastric by the nerve to the mylohyoid. Speaking of the mylohyoid, here's the mylohyoid because it forms the floor of this triangle. And the base is formed by the hyoid bone. Next up is the carotid triangle. Note the boundaries of the carotid triangle are your posterior belly of the digastric, the superior belly of the omohyoid, and the sternocleidomastoid. Within the carotid triangle, you're going to find a couple of interesting structures. Some of the major contents will be as follows. Your internal jugular vein, also called or abbreviated as IJV. You'll find the vagus nerve and the common carotid artery, and then if you follow the common carotid artery superiorly, of course also the internal and external carotid arteries and the branches of the external carotid artery. In addition, here you can also find the hypoglossal nerve way up here, and there's another little nerve which is actually called the ansa cervicalis. In this case it's the superior root of the ansa cervicalis, which hitches a ride on the hypoglossal nerve and then dives down. And you can also find the superior root of the ansa in the carotid triangle. See, if I fade the sternocleidomastoid muscle like this, we have a better view of all the structures that will be deep to it. Here are the different muscles, and here is the major contents. So the internal jugular vein extends all the way up and down here. Your vagus nerve, and your common carotid artery. This is before it actually splits. It splits a little bit higher up into the internal and external carotid arteries. And there is one more nerve here that we should actually already know if we've watched the previous videos, which would be your accessory nerve. Remember, I was mentioning that this is, although it counts as a cranial nerve, it's cranial nerve number 11. It's not really a cranial nerve because it actually originates from the higher, or the first 5 cervical spinal levels. However, if you find the accessory nerve, if you're doing a dissection, you might be able to find it where it crosses the deep surface of the sternocleidomastoid, and then it'll supply motor innervation to both the sternocleidomastoid and the trapezius muscles. So if we now look a little bit deeper into the carotid triangle, we can have a peek here, and here is the thyrohyoid ligament or thyrohyoid membrane. This is interesting because you can see there's a hole in it, and this hole is going to serve as a conduit for 2 structures. One of them is an artery and one of them is a nerve. Okay, so you can see the nerve that is entering through this hole in the thyrohyoid membrane is called the internal branch of the superior laryngeal nerve. This small artery that we can see here is called the superior laryngeal artery, and usually this artery will be a branch off of the superior thyroid artery, which in turn is a branch off of the external carotid artery. And here's the internal branch of the superior laryngeal nerve. Some actually also call it the internal laryngeal nerve. Please note that as this is the internal branch, that means there should also be an external branch, and sure enough there is. See, it actually goes all the way down here, and it goes to the cricothyroid. The cricothyroid is this little muscle that you can see right here, and also on the other side, right here is the cricothyroid. Okay, in the middle you have this here, which is called the cricothyroid ligament, all right? And so the cricothyroid muscle is going to be innervated by the external branch of the superior laryngeal nerve, whereas the internal branch of the superior laryngeal nerve, let's see if we can find it again. The internal branch, you can see here, traverses the thyrohyoid ligament. It is both a somatic and a visceral sensory nerve. That means it'll be able to transmit sensation from the mucosa and the larynx, and also taste information from the upper larynx. This branch, so the internal branch, and the external branch you can see coming off here are both branches of the superior laryngeal nerve, which in turn is from the vagus nerve. Basically, it just arises as a branch from the vagus nerve, and then it descends on either side of the pharynx, and then it divides into your external and internal branches. Whereas, as I just said, the internal branch is primarily sensory, and the external branch is motor to the cricothyroid muscle. Now we're going to move on to the muscular triangle, and I have superimposed here also the outlines of the borders or boundaries of this triangle. And you can see one of them would be the midline of the neck, medially, and then superolaterally you actually have this little part here, this belly of the omohyoid, so that's going to be the superior belly of the omohyoid because the inferior belly is down here. And we've removed a little bit of the sternocleidomastoid, but the sternocleidomastoid would actually make up the inferolateral border, whereas the superior belly, the omohyoid, makes up the superolateral border. If we think about the contents of the muscular triangle, well, inside there would be part of this large gland here, your thyroid gland. Of course, all of your infrahyoid or strap muscles are in here. And, well, speaking of the thyroid, on the back side of the thyroid, there are usually 4 small glands that are absolutely essential to life because they help regulate calcium metabolism, and without those you would actually have a tetanic muscle spasm in the end, and when that actually occurs to the diaphragm, or with the diaphragm as well, that would lead to death. So that would be your parathyroid glands. I might be jumping the gun on a clinical correlation here, but for people that have had a thyroidectomy, it's very important that the surgeon always keeps the parathyroid glands because these are literally essential to life. I just went ahead and deleted that pen that I had. Okay, so again, midline of the neck, sternocleidomastoid, superior belly of omohyoid. So you can see here's the SCM, which is cut. Remember, it's called sternocleidomastoid. It actually comes from the mastoid process on the underside of the skull, right up here. And then it has 2 attachments, one to the sternum and one to the clavicle. Let's have a look at the strap muscles, and with the strap muscles, it's as usual in anatomy, the name is the game. So this one here going from the sternum to the hyoid would be the sternohyoid. We can hide that. Let's look in the deeper layer. Right deep to that is going to be the sternothyroid. So that runs from the sternum to the thyroid cartilage. If I remove that now, we can see down here is the little cricothyroid that sits directly on the surface of the cricoid cartilage and inserts onto the lower margins of the thyroid lamina. So when this little guy contracts, what it's going to do is it actually can laterally rotate your thyroid cartilage, and as it pulls it downwards as well, it will tighten the vocal cords, which means that it'll increase the pitch of your voice. Running right here from the thyroid to the hyoid is the thyrohyoid. Okay, so if we go through them again, thyrohyoid, omohyoid, cricothyroid, sternothyroid, and sternohyoid. So let's finish off this chapter now with a few closing remarks. First of all, you can see here I've highlighted for you in kind of a pinkish color. This is the superior and inferior roots of the ansa cervicalis. The ansa cervicalis is actually called the nerve loop of the neck. See up here where the mouse cursor is, this is where the superior root comes off of the hypoglossal nerve, just stitches it right on there, then it goes down and loops back around. This is the inferior root then. And so the interesting thing about this is you can see all these branches going off to the strap muscles, and so the ansa will supply 3 of the 4 strap muscles. That would be, in that case, the omohyoid, the sternohyoid, and the sternothyroid. The exception is the thyrohyoid, which will be innervated by a nerve called the nerve to the thyrohyoid. For clinical correlation, as we are here in the midline of the neck, there are two approaches, or probably at least two approaches on how to create an emergency airway. The first one, as you can see where I've indicated the red line, would be a so-called cricothyrotomy. It's also called a cric, or thyrocricotomy, or cricothyroidotomy, or inferior laryngotomy, and so on and so forth. But what's important is actually that a incision is going to be made right here through the skin and the cricothyroid membrane, and that's has the purpose to establish a patent airway during like a life-threatening situation. For instance, like an airway obstruction through a foreign body. This procedure, however, is always a last resort procedure when, for instance, the orotracheal or nasotracheal intubation do not work, or if they're contraindicated. Also, the cricothyrotomy is actually easier and faster to perform than the tracheotomy, and it doesn't really require manipulation of the cervical spine, and it's associated with fewer complications. If we just move a little bit further down, here's your trachea. So the tracheotomy, as you can imagine, is similar. Tracheotomy or tracheostomy, because a stomata is actually an opening or an ostium. That is just the creation of an opening in the trachea somewhere down here. Again, this is an emergency operation, has to be performed rapidly in cases where there is sudden obstruction of the airway for the same reasons as the cricothyrotomy. The difference is you can have a more permanent, longer duration tracheostomy tube in the trachea, whereas the cricothyrotomy is actually only a very short term, so it's a temporary measure until you can establish a definite airway.